Okay, now we move forward because we talked a lot about the problems and what's happening and whatnot. But we also wanted to share with you some nice solutions. So we will follow the waste hierarchy and focus mostly on reducing and reusing. And we'll start with our next speaker for today, Francesco. If you see, yeah. Okay, so he will talk about. You can join. Well, I will let you present what you're going to talk about because I think you do it way better than me.
Thank you. Good morning to everyone. I'm Francesco Bortolucci. I come from Italy. I am a gastroenterologist, a clinician, and I live and work in Venice, the most beautiful town in the world, as you know. I am one of the few Venetians. We are very few, but very proud. So we speak about, first we speak about choosing wisely. Choosing wisely, as I think you know, is an international campaign that was born in the States about 15 years ago regarding appropriateness. In synthesis, there is a lot of scientific societies that decided and established confronting with the consumers some recommendation regarding procedures of diagnosis of treatment potentially more harmful than beneficial for the patient. The problem regarding the so-called over-diagnosis and over-treatment, and that's the same I have in Venice with over-tourism. For me, the solution is napalm. This is a picture. In Italy, we have Choosing Wisely Italy that we are working some years ago, and they are vehiculated by Slow Medicine, an association who has the slogan for an healthcare sober, respectful and fair. And we are expanding the project. Recently, we decided to go green. Appropriateness is sustainable by definition, so choosing wisely is sustainable by definition, but we want to go over and more precisely we elaborate, I'm sorry, I'm Italian. We elaborate recommendation dedicated to green endoscopy. The problem is regarding sustainability, then improving the appropriateness may be very, very important, as you see later. This is our recommendation. This is a recommendation of my scientific society, the gastroenterology hospital gastroenterology in Italy. Regards, for example, don't practice endoscopic examination when we have low alternatives with low waste or less invasive, or don't take mucosal biopsies which are not necessary for the management of the patient. Don't plan elective endoscopic procedures or inpatient basis when we can do outpatient, or don't use single-use endoscopes as not necessary, and last, don't abuse of drugs intra or peri-procedural. In effect, in the last 3-4 years, there is a big debate in gastroenterology regarding green endoscopy. There are a number of papers, both from Europe and the States mainly, but not only. And we have some difficulties to expand the program. For example, we have financial problems. We have quality control because there is a problem with infection transmission, but also, last but not least, the fear of missing lesions or malpractice, so the so-called defensive medicine. And then we have a problem of knowledge gap. We have no data, no real data, and no guidelines, specific guidelines. But we can do it. Europe, the ESGE, this is the European Society of Gastrointestinal Endoscopy, the American Gastroenterological Association, are activating a task force regarding this problem. And this is the first recommendation, the statement of the European position paper. They recommend adopting immediate action. We have no more time, as you know. This is a synthetic picture of what we can work on. We have the problem of reusable caps, clothes, and so on, plastic. We use nitrile gloves currently. And the procedure, the indication, the appropriateness, and then we are working on telemedicine with some research by me, and the transportation. The first thing we can do is to quantify the problem. We don't know what's the carbon footprint of every our activity, but we are beginning. This is a recent works published on the gastrointestinal endoscopy by me and Luca Eli and co-workers. We calculate the carbon footprint both for gastroscopy and colonoscopy. And this other work, the same work, but regarding the pre, during, and post-procedure. This is a first attempt to define the carbon footprint and the greenhouse emissions of our activities. The problem is we perform a very high number of procedures. In the States, there are 18 million endoscopic procedures a year that produce a big amount of waste. As you see, it's about 120 soccer fields, 1 meter depth of waste. In Italy, 8 million the waste for the procedure year. Remember that endoscopy is the third largest contributor to waste production in healthcare. So we have a very high number of procedures. Simple ideas, we need also simple ideas. This is a work published on GATT, big journal of gastroenterology, a very simple one. They only change the distribution of waste basket in the endoscopy suite. Only change the waste, the baskets. And they have a 25% of decrease of waste. A little thing, but I think we can do it now in our suite. We have not to wait for the future or for systemic resolution of the problems. Another simple thing, we use water to irrigate the colon during colonoscopy. We used sterile water, it's not necessary. We work within sheet, and tap water is sufficient, is enough for the procedure. This is a little thing we can do now. Another problem, single-use accessories. We use a lot of devices. Years ago, we have a number of reusable accessories. Then, due to infection problem, to company initiative, we go to single-use. Actually, we use about 90% of single-use device in our activity. But there is a number of devices we can reuse without any problem. We are basket, biopsy forceps, sphincterotomes, and so on. It depends on regulatory rules. They are different in various countries, but maybe we can come back to the past. Other problem, the endoscopes. We use a different endoscope for different procedures. Particularly, we use duodenoscopes for the procedure to the biliary tree. The shape of the duodenoscope is particular, and that means that we have a higher risk of transmitting infection from one patient to another. And for this reason, the companies develop single-use duodenoscopes. It's quite interesting, but it's very debating. For example, if you see, obviously there is a big amount of waste if you use a single-use endoscope for any indication, less if you use for selected indication. There is a big debate in gastroenterology. The reasons are simple. Pros are the reduction of the infection and no disinfection and reprocessing. But cons are the carbon footprint due to production, transportation, more waste, and more cost. Recently, there is a Delphin consensus, such as in consensus within the expert, who stated that the indications are only for high-risk patients for receiving or transmitting infection. So actually, the only indication for use, single-use endoscopes was in this setting of patients. Last but not least, appropriateness. In the beginning, I speak to you about appropriateness, and now I remember that this has large data from Italy, 90,000 endoscopy, and the rate of inappropriate indication varies from 20 to 35%. 1/3 of procedures we perform are not appropriate. This is a big amount of greenhouse emission, I'm sorry, that we can obviously reduce. We have position paper. This one was the European one. This one was the Italian one regarding this topic. It's very important for us. If you have less procedures, we have less waste and so on. More, in 70% less and more of procedures, we take biopsies of the mucosa for histologic examination. It carries a carved food significant because there are small amount for a high number of procedure. And in fact, we are discussing, I think in the afternoon, maybe during when we're speaking about the screening of the colon, because there is a debate of the policy of reset and discard or diagnosis and leave for little polyps with an endoscopy appearance of very low probability of malignancy. So this may be a way to reduce the biopsies. Another way is less invasive procedures before endoscopy, for example, H. pylori in the feces or calprotectin in the feces too. We are searching to reduce the endoscopy, the not appropriate endoscopy, the not appropriate biopsies during the endoscopy. Recently, we performed in my scientific society a survey between associates and regarding the information they have and the consciousness they have on the problem of sustainability in endoscopy. We have about 200 response, not so more, but they indicate, I'm sorry for the Italian, the necessity of a sensibilization campaign, the guidelines, the certification, green certification, so on, device, low impact device, and waste disposal. This is the argument we have to develop in the future. We are working about a program of certification step by step regarding sustainability in endoscopy in Italy, and I hope we have some results in the next future. Thank you.
Does anyone have any questions? Yes, I see already a question. So, Anders?
Yeah, we don't use single-use endoscopes. We clean them and disinfect them. And I don't know how many of you have tested endoscopes. It's terrible. You have to swallow something thick like this. It's a long tube into your stomach and then biopsies. So it's nice if it's clean and disinfected. The problem is that you cannot sterilize it by heat. It's too sensitive, so you have to do the chemical disinfectant. And then we had, in previous times, we had aldehydes. It was a big occupational problem. People got allergies, and it smelled terrible. And some years ago, we had changed all these sterilizer machines, converted them into, I think it's hydrogen peroxide, superoxide, something. And now we have eliminated the occupational problem. It's more expensive. We had to change these machines, but it was actually the reason we could do that was actually for the
No, the problem regarding the single-use endoscopes, we have no great infections in usual endoscopy. We are focalized on the particular problem regarding duodenoscope. This is a little bit larger than the endoscopes, as you see, and the particular shape in the edge of the endoscope that we have a noodle that we can take off, and in the edge of the endoscope, maybe there is the biofilm residual that can help to have infection. This is a specific problem. This is the only one actually we agree in the single use. Not so much. In fact, in the survey, as I told you before, in the survey we have the majority of answers over 60s. The young gastroenterologists have very little interest in the. It's not a good thing for me, but I think we have to go on. Yeah, choosing wisely is a complex program because we stated the recommendation, but we have to implement them. We have, for example, a difficult. We have to. The trick of choosing wisely is the relationship with the consumer association. In Italy, for example, they are regulated by Altro Consumo. In the States, by Consumer Report. This is maybe the relationship between a patient and a clinician. And may be useful, but it's not so simple to implement. On the other side, we have problems in the relations with the prescriptors, the GPs in particular. We are trying to popularize the campaign. I remember that in Italy there is the national system of guidelines who has a legal relevance because there is allegedly the law jelly that stated that a judge may judge me according to the good clinical practice, and the choosing wisely is in the national system guidelines. This is a trick we use to convince the prescriptors to adhere to the good, because they are not guidelines but good clinical practice, formally.